Everything that could go wrong has gone wrong, and we need to talk about it because the learnings don't just apply to this case, but apply to other aspects of health as well. The results from the Keto CTA trial were just released, and that's what we'll be going through in this video.
Has the keto lean mass hyper-responder study gone horribly wrong? Hi, I'm Dr. Eric Westman, and welcome to my channel where I review and debunk nutritional misinformation online. Big news in the last few weeks in the keto-verse, the keto low-carb world, in the science realm, a publication long awaited on the one-year results of those who have super high LDLs and ApoBs. We're going to get into this in this video, and it's really just the start because I'll probably be doing multiple videos as more information comes out and as more people kind of get distracted by things that I don't think are so important. I think this study is super important, and we're going to hear a doctor critique the study. And wait till the end of the video because this is a classic example of trying to squeeze blood from a turnip or trying to criticize, your child for doing something that they haven't learned how to do, or in other words, is taking a pilot study and expecting that it answers everything. That we just don't expect that to happen in the research world, but it doesn't mean other people will expect it and criticize it for that. So let's see what Dr. Brad Stanfield has to say. I like his videos in general. He takes studies and uses evidence-based critical appraisal methods, but it's not always the study, it's often the context. And I'm going to give you some context for the lean mass hyper-responder study in this video. So we might call this the video number 1, part 1 on the LMHR study.
This was a trial of what the authors term lean mass hyperresponders. So these are people defined as a triad of elevated LDL cholesterol along with elevated HDL cholesterol and low triglycerides that tends to occur in lean, generally healthy individuals adopting a low carbohydrate diet. But as the authors say, irrespective of the metabolic and mechanistic drivers of this lean mass hyperresponder phenotype, there is understandable clinical concern, especially among those lean mass hyperresponders with the most extreme profiles, including LDL cholesterol levels of in excess of 500 milligrams per deciliter. So if I saw a patient in the clinic with that high a level of LDL cholesterol, I would be incredibly concerned, and here's why. All of the cardiology guidelines, all of the medical schools, all of the hospitals, they all advocate for lower LDL cholesterol levels to lower our heart disease risk. And those guidelines are based on papers such as this one. So this one was published in the European Heart Journal in 2017. And it was looking at the link between LDL cholesterol and heart disease. So this study combined over 200 prospective cohort studies, randomized controlled trials. It involved over 2 million participants with over 20 million person years of follow-up. And what they found is a remarkably consistent dose-dependent log linear association between the absolute magnitude of exposure of LDL cholesterol and heart disease. And it's easier to see on the graph here. Basically, every single line of evidence that we have seems to indicate, again, when we combine it together, that the more LDL cholesterol that our blood vessels are exposed to, the higher our risk of heart disease. This is why in the clinic I work hard with my patients to lower their LDL cholesterol and ApoB levels.
So how can you argue with the enthusiasm of this doctor? Well, I was in his position some years ago, and in fact, in our first study of a low-carb, high-fat Atkins-type diet, there was a dietitian who complained to my hospital director, and they tried to shut the study down. Because 25 years ago, when I looked at an LDL cholesterol, or when other people thought of an Atkins diet, I had these kinds of same concerns. But I went around and visited doctors who were using the method, including Dr. Atkins, and satisfied myself that people were not dropping dead after eating fat. So I decided to study this, and yet the concerns immediately that I got were that you're going to kill people. That study that I did was not shut down, but there were more reports that I had to file to prove that people weren't dying over 6 months, just 6 months. And so the context here, and Dr. Stanfield, I totally respect your enthusiasm and all that, but there may be another way to go about it. So the hypothesis that the LDL in the blood is necessarily the cause of heart disease has been debunked over and over, where that people can get heart disease with low levels of LDL. And then people with high LDLs don't necessarily have heart disease. So to me, that was like, well, okay, maybe LDL isn't the cause or always the cause, but it's almost like going into a belief system that if you criticize or even questioned the idea that LDL is a problem, and in the course I wrote for the Adapt Your Life Academy, I went through all of those studies that Dr. Brad just showed. And what struck me is that these associations are not causative. They're not at the level that you would see with tobacco and lung cancer or tobacco and COPD. So the association and the relative risk may seem high, but the absolute risk and the causal mechanisms really aren't there. So back in the day, after 6 months of following people on an Atkins type of diet, nobody died. And yet everyone told me that I was killing people. I didn't want to kill people. I don't want to kill people, even today. So the context that's missing with all of the clicking you're going to hear at first on this study is that everyone thinks that if you have an LDL of 580, you just heard that he would be super upset about it, it would necessarily cause heart disease. And 25 years ago, I was accused of killing people. I'm not killing people, okay? But so the context here is that if you could follow someone with an LDL of 590 for a year or even 5 years, in the study that we're going to talk about over and over that's now out, there are people who self-reported 4.5 years of super high LDLs who had no coronary atherosclerosis at all. And so the baseline data that were published last year were so remarkable that it was ignored, pretty much. And now you know, it really is a pilot study, meaning you don't need a sample size. You're not proving that there's a difference between two groups where you need a power calculation. A pilot study doesn't even necessarily have to have one final outcome. So this is going to be the first critical appraisal flaw here, that a pilot study is just run a bunch of people and see what happens. And so the first remarkable thing about the study that no one's going to be talking about is nobody died. The prediction that, oh my gosh, tell me if your doctor's response, if you have just a little LDL elevation, isn't, oh my God, you're going to die, you better go on a drug treatment, or oh my God, you're going to die and you better get off that diet. Even some of my colleagues are saying, well, you know, okay, hedge the bet here, so let's lower your LDL by changing the fats in the food, and you can do that. But I'm not sure it's necessary. So the first context for this study is that nobody would fund it. We're talking about funding, who does funding of trials, and so Dave Feldman, who is a computer programmer, and I just reviewed a video of a computer programmer who's trying to come up with the ideal diet based on computer algorithms. So you can actually be logical and kind of say, well, you know, something doesn't make sense here, because one of the leads of the study had super high cholesterol levels and was fine. He was not developing the coronary heart disease or other atherosclerosis. So the context here is everyone thought that you go on a high-fat diet, you would die. Okay, they didn't say when, but the fear-mongering about it 25 years ago for me, I realized, well, it didn't happen. Yes, I visited doctors, Dr. Atkins, other clinical programs, but again, I had to prove it to myself. I wasn't going to trust other people's opinion, especially in the context of everyone's afraid of fat in the diet, afraid of LDL in the diet. And in my first study, randomized trial that I did, that was the second study that we did, I got concerned about an LDL elevation and dropped the person out of the study at the midpoint because I was worried about it. Now I'm not worried about it. So 25 years have passed. So a lot of doctors, including Dr. Brad, are coming at this like I was 25 years ago, where, oh my gosh, I'm in the paradigm of LDL is the cause of this, and you have to reduce it and get off that diet, you know, well, and take a drug. Or, so hang on, just take a deep breath. Nobody died. Nobody died in this study. That's number one, because the prediction was really bad, not only in the context of this study that we're going to go about critiquing a little bit, or even all of the clinical trials now over the last 25 years. In fact, I can think of just one death in a study, but it was related to diabetes management. So that if you don't drop the insulin immediately, you might get low blood sugars. And this is why if you're in a clinical setting, you're on medications, do this with a doctor that generally do a low carb or any kind of effective diet, or even drug now, all these drugs for weight loss and diabetes reversal. Make sure you manage those blood sugars carefully. But so everyone predicted with the LDL hypothesis that if you had an LDL of 590, even for a year, you would probably just get terrible arterial blockage and even have a heart attack. Ask your doctor, if my LDL was 500 for a year, would you be concerned? You're going to get a visceral reaction, kind of like the enthusiasm of Dr. Brad. And I understand that. I used to have that reaction too. So the context here is that nobody would fund this research because everyone knew that LDL was bad and they were all going to die. It would be unethical to do the study. So Dave Feldman created a GoFundMe. He asked the people who were having these results, or me, just because I'm in this world scientifically and nobody will fund it, I put in money as well to help fund this study. It wasn't governmental funded. It wasn't done by a drug company. And it's a challenge of the LDL hypothesis because there were people who had so high LDLs. They make my friends who are internists quiver, and they not only did they not die, they had minimal progression of disease. So now we're going to get into probably over the next year, I'll be doing several videos about this because as the data come out, there's a preprint that everyone's talking about, and there's going to be a clinical relevance study coming out. So I'll revisit this study for a long time. But let's just step back. So a pilot study is just taking some people, seeing what happens. Why would there be such a reaction against a pilot study? This is the fundamental issue. It's because everyone predicted the opposite. And now you're going to get nuance. Well, they didn't measure the right thing, or there was progression. It doesn't mean you're perfectly immune from the progression. And no, the main point is there wasn't slathering of the arteries over even a 5-year period, which everyone predicted. And now you'll get we didn't predict that, and yeah.
I want to prevent disease rather than treat it. So coming back to the Keto CTA study, the authors wanted to look at these people that had very high levels of LDL cholesterol and who met their phenotype of being a lean mass hyperresponder. So they followed 100 people up, again with this triad, over a 1-year period, and they were looking at plaque buildup in the blood vessels. And before any human study is done, it needs to be pre-registered on a clinical trial registry such as this one on the page. And basically this just means that there's nowhere to hide. You're outlining what you're going to be measuring and roughly what you're going to be doing. And so you need to publish these results. And you have to select a primary outcome, as in what is the one thing that you're trying to measure to prove or disprove your hypothesis.
So Dr. Brad is applying great evidence-based medicine techniques in a book, critical appraisal sort of table. These are the things you would go through. A pilot study doesn't have to go through those things because, again, we're just looking. If you had an alien come from outer space, you would study it without regard to a primary outcome measure. But by the book, if you're doing a randomized trial or even a kind of a secondary analysis, I totally agree. You should have a primary outcome and you should stick to it and of course show it and that your p-value, if it's a 0.05, it only applies to that outcome. This is really super good critical appraisal, but it's misapplied because it's just a pilot study.
So for the study, they were using the percentage change in non-calcified coronary plaque volume. That's critical because when we're going through the results of the Keto CTA study, we need to know what the primary outcome is. So we're looking at the results section now. But when we go through the study, we don't see the raw data. All we see is this graph here. So you have to pixel peep. You have to try and figure out, based on this trend line, how much has the non-calcified plaque progressed. So we don't know, and that's a massive red flag. Every single study should be publishing their primary outcome in written form, along with the statistical analysis, so we can actually see for ourselves what is going on. Have we proven or disproven the hypothesis?
Yeah, as I have gone on in reading trials, and I would rather have this presentation where you're seeing everybody's before and after result rather than just the mean, just the average. The old saying is you can hide some dirty things in the mean, just looking at the average. Like on average, no planes crashed. Well, but you don't even want one plane crash. Anyway, I think he's a little too critical, a little too fast, but I'm going to see this over and over, I'm afraid.
So again, all we're given here is an image. So how much has the non-calcified plaque progressed, and is that rate of progression concerning? So we don't know.
But nobody died. So this is the misappropriation is, no, people thought that this level of LDL would be lethal. Not just a risk factor in progression of disease, but lethal.
But the authors in their previous research, they gave an estimate as to how much they thought the plaque was going to progress over that 1 year time frame. So they say they gave a conservative estimate of mean plaque volume change of 7 units, given that the subjects are substantially younger with little to no risk factors. So that's really important. Before the study began, the primary outcome, as in the thing that they were going to hang their hat on in terms of their hypothesis, was the change in non-calcified plaque volume, and they were expecting that to be roughly 7 units over the 1 year time frame. And it was only after massive pressure on social media that the authors finally gave us this result in written form, and it was 18.8 units. So that's a lot more than what was expected, and they posted it alongside a meme for some reason. All of this is incredibly concerning.
So hold on. One of the other interviews I've read by the principal investigator, who is probably the world's leading researcher using this CT angiography methods, has explained that the preprint publication that gets out there now, the publication world is really kind of strange, where they're putting preprints out and now people are criticizing the preprint. Well, you can still revise the preprint. It's not the final publication. And the other thing that I just have to remind you, that this was a GoFundMe sort of funding study where there are virtual investigators here. They're linked in different actually parts of the world. And when I say it was just a virtual or funded, crowdsourced funded, is that they were not able to charge for media coverage or having a unified a place like Duke here. There's a whole staff that will help communicate the results of your study into the in fact, they don't really want me to talk directly to the press, so they'll facilitate the press connection. And so now you have social media, and so the idea that there's going to be one and final answer of what went on is being used inappropriately because of, again, this is a pilot study, and yet why does everyone care about a pilot study? Okay, well, in fact, in my evidence-based medicine world, I would say, well, that's great, I want the second study, and so just relax. I want the second study. Although what I've learned in this first study is nobody died. In fact, if we're quibbling about how much progression of atherosclerotic plaque is, it didn't clog up entirely. We're talking about minimal amounts. And I'm afraid that didn't get emphasized so far, but it is emphasized when you talk to Dr. Budoff about it. And the hullabaloo about this is because it's threatening the whole LDL idea. The figure that no one's talking about, and we'll go over it again in future videos, is the one that shows the LDL or ApoB, which really is synonymous, very close to the same thing, had no relation to plaque progression. And so if LDL is the cause, necessarily the cause of atherosclerosis, you should have seen some sort of massive change. Nobody died. In fact, there was hardly any progression. It was similar to other types of progression you might see based on aging alone. And that's something that will come out over time. So actually, I don't think the study has gone horribly wrong. They're trying to be super critical of look, the individuals just, they came to the ball, they weren't perfectly dressed, but they had the ability to do a study like this, which is unbelievable, actually. I think this is a great study, but don't try to do too much with it.
The fact that the plaque progressed a lot more compared to what the authors were anticipating, and they didn't report it correctly, these are massive red flags. But how does that 18.8 number compare to other results? So if we have a look at the paradigm study, so this is where they measure the change in atheroma for high-risk individuals, and this was over a 10-year period, so they could roughly see how much was the percentage change for each year. And if we overlay the Keto CTA results, it's damning. The people who participated in the Keto CTA study, their plaque progressed a lot more compared to even high-risk individuals from other studies. To drive this point home, there are separate cohort studies that we can have a look at. So a non-diabetic cohort progressed their plaque by 2.8 units over a 1-year period. A diabetic cohort progressed by 34.3 units. So the Keto CTA results are roughly in between that. So again, none of this is painting a good picture.
And yet nobody died. So again, the context, please. It's a pilot study. You wouldn't be necessarily making these comparisons. And I've talked to the authors and asked for the nuance and all that, and they really wanted to show the heterogeneity, that some people had very little change at all, and some people had more change. And so here, everyone's asking for an average change, when what they saw shown in those graphs is that there's tremendous heterogeneity or different individual effects. And so again, don't make these comparisons. Let's get a second study, and hopefully they'll be able to continue this. Except, why would there be such a hullabaloo about a pilot study anyway? Because it's threatening.
The rate of progression of non-calcified plaque for these individuals in the Keto CTA study is incredibly concerning. The fact that it wasn't reported correctly is incredibly concerning.
I don't agree.
And then the coverage on social media by these authors, again, is incredibly concerning.
I don't agree.
Because online, the discussion about the study from these authors has generally been to say that there's no correlation between blood cholesterol levels and plaque, and people are believing this.
But it's true. So you have to look at the other figure that these other people aren't showing, which shows there's no relationship between LDL and plaque progression. So again, it's a bit threatening, isn't it? Now in my clinic, if you're one of my patients, we talk about measuring the arteries directly, not so concerned about the total in the LDL. We're concerned about the triglyceride and the HDL. That's called metabolic syndrome. And even at the end of the day, we discuss whether we should measure the arteries directly. Get that CT, which shows the coronary calcium score, or the ultrasounds of the arteries, and not get so uptight, because in these data, there are people who had no atherosclerosis after 5 years of super high LDLs, which flies in the face of the idea that LDL will always cause a problem.
When this is the reality of the situation that's summed up perfectly by this meme. So we want to ignore that lean mass hyperresponders have rapid plaque progression. Instead, we're going to focus on lean mass hyperresponders have only rapid plaque progression with no difference between very high and extremely high LDL cholesterol levels. This is completely missing the point, and I'm getting concerned because I see people in the clinic who have got very high levels of LDL cholesterol, and they don't want to address that because of what they see online. Every time that I post something on social media, to be honest, it terrifies me that I've got something wrong. I have to double check and triple check everything and make sure that I'm following the clinical guidelines, because I know the potential damage that I can inflict on the population.
Yeah, so I remember thinking this way, and it's taking the guidelines. Dr. Brad started with world guidelines and showing studies that really didn't prove that LDL was the cause, and the idea that some people don't get a problem with high LDLs doesn't compute. So hang on. If it's a different metabolic state, if the LDLs are providing a normal function and they don't have the same atherogenic potential, this is possible. And the idea that the mainstream medical world, even organizations, wouldn't fund it, and that an individual had to get money from people like you and me to fund it is very important to know that context. Don't quibble yet about, how much and compared to other groups and all that. The big picture view is that something different is going on.
If I'm telling people something that's wrong. And I, again, see this in the clinic, where people are under the impression that if they're on a keto diet or they're a so-called lean mass hyperresponder, if they have high LDL cholesterol levels, that they don't necessarily need to worry about it because of some of the research and commentary around studies like this.
So the pattern of cholesterol matters, I guess. And in this group, if you just become very narrow, they had really high HDL levels, which actually, even in the old paradigm, is protective. And yet you've seen that eroded over the years because there's no drug that can no drug that can raise HDL, because it's about the fat in the food. The fat and cholesterol in the food raises the HDL. And the study that tried to manipulate HDL with a drug didn't show that it was helpful. So there's been an inappropriate, I think, emphasis on LDL as the only thing. And yet, maybe there's something else going on. And the idea that there's so much noise about this just little pilot study is because it was very well conducted with the world's leading researcher of the CT angiogram. He's done many, many other studies, and there's now a new analytic technique. It's called the Clearly AI. So it is actually maybe even more sensitive than other measurements that have been done. So over time, we're going to talk about how is it really fair to compare a study now with a super detailed sort of analysis to an older one that might not have even seen that kind of change. So there may be changes before, but it just wasn't a good enough evaluation to see it. So there are a lot of things to talk about in this study, but the main message is I'm not so afraid of it anymore, having a high LDL under the context of a low carb diet. And we, instead of worrying and then giving drugs, we respond by measuring. And you can get these measurements these days. It's not always covered by insurance, but what I've learned is that you want to measure things. You don't want to just assume.
And I have to spend a lot of time going through the research with these patients. And oftentimes I don't manage to make much headway because they've been following these influencers for a lot longer compared to a 15-minute consultation that I've got as a primary care doctor with the patient sitting in front of me. And apologies if I'm getting a bit worked up, but I see the consequences of this, again, in my clinic, where people are having heart attacks and strokes that could have been prevented if we managed to control all of their cardiovascular risk factors, including their LDL levels and ApoB levels.
Yeah, well, so I like Dr. Brad as an enthusiastic doctor, and here you just got to relax these super, critical elements. It's okay that the primary outcome that was there before wasn't in the preprint. I'm told it's going to be in the next one. Why a peer reviewer didn't pick that up and make them do it is another issue. I don't know. Apparently the peer review process was a fascinating thing to go through. So again, 25 years ago for me, I was as worried as Dr. Brad. I'm not worried now. And it's because of the clinical experience. It's because of the idea that there is not an impenetrable fortress of treatment of LDL, and it's not just the doctors knowing and then telling you. It's a relationship, and an advisory relationship we should have as doctors and patients and people. And the concern that, he kind of is typifying what I hear my patients say about other doctors in my area, is that in fact, one of my patients, the doctor fired her because she didn't have any atherosclerosis documented by all of these scans, but still wanted to treat the cholesterol with a drug. There is a guideline even through the radiology groups that say if you don't have any evidence of atherosclerosis, perhaps you shouldn't be on a pill to prevent atherosclerosis that you don't have. It's pretty logical when you think of it that way. A cancer doctor wouldn't put you onto chemotherapy and radiation on the, looks like you might have cancer. No, we can know if individuals have this in a primary prevention sort of situation, like this was, the lean mass hyperresponders. Nobody had heart disease here. That's a different discussion altogether. And no one had diabetes. I think that's a different discussion. But here, if you're following a keto diet and you're measuring ketosis, they did that over this 1 year. It was reassuring for me so far with the news and the data that I've been seeing so far. But at the same time, it has made me go to that measurement of the arteries themselves rather than just focusing on the blood test. And that is disruptive of the guidelines and traditional clinical care. I understand that. I hope this is helpful and you like it. There'll be more videos on this study over time. And please like, subscribe. Hey, send this to a friend or a loved one who is getting grief about the diet that they're doing. I use this study and the figures that show that LDL has no relationship to plaque progression, and the figures that show 80% of folks had no coronary disease at all, even though they had super high LDLs. So there are going to be some subgroups that you'd be particularly worried about. Perhaps why not measure directly in yourself is kind of my take-home point. It might cost a little money if insurance doesn't cover it, but the idea that LDL is always the cause and necessarily the cause, and if it's high, it's going to cause immediate clogging of the arteries. This is the fear, right, that was there. That didn't happen. Nobody died. If you like, please like and subscribe and ring the notification bell. Look for new content on Wednesdays and Fridays. If you enjoyed this video, consider joining our YouTube membership for early access and exclusive live Q&As with me. Just click the join button below or support us with a PayPal in the description.